Perfect. Thank you very much. So, good evening, everybody. I'm Sachin Khode, a marketing manager from Merck, and gives me a great pleasure to extend my warm welcome to you all for this for this program called as UC International Speaker Symposia, which is happening today. Again, we have an excellent lineup of speakers and highly experienced panel with us today. And to begin the proceedings, may I invite Dr. Meenu Walia, ma'am, to set the context today. Dr. Meenu Walia, ma'am, she is a chairperson medical oncology currently at Max Healthcare, Delhi. She is the first DNB medical oncologist of India with 26 years of experience in medicine and 15 years of experience in oncology. She is member of multiple national and international oncology societies. She is principal investigator for several randomized multicentric international clinical trials too. Published extensively in national and international peer-reviewed journals, and authored a book called as Tips for Happiness in the Shadows of Cancer, which is published in multiple languages. Dr. Meenu Walia, ma'am, it's our privilege to have you us today for this meeting as a chairperson. Now I hand over the session to you. Over to you, ma'am.
So thank you, Sachin. Before I begin, I must thank the organizers, Merck and team for the opportunity, and especially to address this very burning topic of the management of urothelial cancer. Can you share my slides or yeah, they are there. So we all know that urothelial carcinoma is a problem all over the world. Although it is the India at present ranks as at the seventh level as far as the incidence of the bladder cancer is concerned. But if we look at the mortality, then the things are much more worse. I mean, it is at in the context of being lethal cancer, it is almost the third lethal cancer lethality or the mortality. In it, India ranks at the third level after China and US. That indirectly reflects that majority of the cancers that are detected in our country, either they are detected late or they are in advanced stages, or they might also probably be reflecting the more aggressive or the typical biology of the cancers which are seen in our part of the world. So going to the next slide. So majority of the patients, they present with either locally advanced or metastatic bladder cancer, and all these patients, whether they are locally advanced or metastatic bladder cancer, they generally have a very poor outcomes. And 50% of the patients, even after an operable cancer, even after cystectomy, 50% of the patients will relapse, and majority of these relapses are systemic relapses. And as high as 5% of the patients will have metastatic disease at the time of diagnosis. So most of these cases, whenever they relapse, they are invariably metastatic. And once the cancer is metastatic, then the treatment options are very limited. Can I have the next slide? Okay. So what is the current landscape of management? We all know that at most of the whenever we see a patient, we generally try to classify them. There was an era when it was only used to be platinum was the main backbone of therapy, and we used to classify them as platinum eligible or platinum ineligible, and within the platinum also cisplatin eligible or cisplatin ineligible. Better results were seen with cisplatin compared to carboplatin, but those who were cisplatin ineligible, we used to start with carboplatin. Recently, our country, I'll rather say we are fortunate that now we also have enfortumab in our country now, which is available for the Indian patients. So the first line options definitely remain a combination of enfortumab with immunotherapy, that is pembrolizumab, but still it is beyond the reach of majority of our patients. The other options that we commonly use for our patient is a combination, the doublet chemotherapy, platinum with gemcitabine. And also, in some cases, we are using IO combination also. And these are generally followed by wherever we use IO, we generally want to use IO in the immunotherapy in the maintenance arm also. However, once the disease relapses, then the options are very limited, and majority of these drugs are not available in our country. Can I have the next slide, please? So what is the objective of today's meeting? Today we wanted to discuss that what are the various treatment options of this highly aggressive carcinoma that we see, and what should be the optimal treatment sequence. And we want to learn not only from our colleagues but also from our esteemed faculty that what have been their experience and the real world evidence, the real world data, what helps us in making decision and what should be the right sequencing for these kind of patients, and how important it is not only the quantity but also the quality of survival in these metastatic cases, and how these different histological subtypes they behave. And let's with that context I want to set the ball rolling, and will be eager to learn from my colleagues and what we can do in this context. Thank you, Sachin. Over to you.
Thank you very much, Dr. Meenu Alia ma'am, for setting the stage so clearly. With that background, now we move on to our keynote session. And next slide, please. And it's our privilege to have Professor Alison Bertel as today's keynote speaker. Professor Allison, she's a consultant clinical oncologist at Rosemere Cancer Center and Lancashire Teaching Hospital. She is also honorary clinical professor at University of Manchester and University of Central Lancashire. Professor Allison Bird is leading consultant clinical oncologist and key national voice in uro-oncology. She advises Macmillan and trustee and medical advisor to fight bladder cancer. She also served as Secretary British Uro-Oncology Group. She has held major national roles, including chair of NIHR Bladder Renal Group and several guidelines group too. She has led multiple clinical trials, but most notably as chief investigator for the practice-changing pouch trial. She has several honors, including 70 Stars Award and Researchers of the Year Award. A strong advocate of a trial for every patient, she is also passionate for singing, musical, theatre, rugby, football, and something which is very close to every Indian, cricket. So with this introduction, I request Professor Allison to start our keynote session. Yeah.
Thank you. Thank you so much for that. And I hope that you're able to both hear me and to see my slides. If someone could just say, yes, I can.
Yes, Alison.
And we won't mention the cricket after the recent fiasco from the other Thursday. So I'm so delighted that you've asked me to come and speak to you today. And I really hope that at some point we'll be able to do this face to face, hopefully coinciding with some major cricket tournament. That would be wonderful. So I'm really passionate about the fact that unfortunately many of our patients don't have access to effective first-line systemic treatment of any sort. We can have all the new drugs we want, but if patients are not getting in to see us, it doesn't matter. And we know from a variety of surveys that between 1 in 3 and 2 in 3 people never get any treatment at all. And we know that this can be lots of reasons. It can be because the healthcare professionals aren't trained in the particular drugs. It might be difficulty access because of living in a rural community, or it might be that patients stop treatment too soon because of side effects. And we know that we're not very good at asking patients what they want. So this is Petra Grievous' survey, which showed that actually oncologists, we put all our weight behind survival. But the patients have a different viewpoint. The patients' preferences are always based on treatment experience alongside survival. So we need to add that into our shared decision-making, because shared decision-making means that we start off by finding out the wishes and preferences of the individual person and their caregiver. And then we start looking at the guidelines and the level of evidence to add in the appropriate treatment for that patient, not just what it says about their cancer. And access and cost isn't just about drug cost, it's about travel costs, time off work for the person and their caregiver, the support that they're going to have whilst they're having treatment. Now, you have far better support as members of an extended family than many of my patients would have. And also then we add into this quality of life, duration, and what happens today in terms of our treatment means that we have to choose other treatments with more care down the line. So we know that we've been lucky in that finally we've had new treatments now for 6 years. So in 2020, we had the Javelin bladder study, and then it's 3 years nearly since we had the EV302, the Keynote 39 study, and then the little bit of a damp squib that was the Checkmate 901 study. So Dr. Walia has already alluded to our treatment algorithm and how we have a number of choices in the first line setting affected by all the things that I've just mentioned. And I'm going to take you on a whistle-stop tour of where we currently are. Starting off with patients on platinum-based chemotherapy and then going on to maintenance treatment. Now, the first thing to say is that the response to chemotherapy is actually much better than we ever think, because these are all the studies that have been published ever looking at platinum-based chemotherapy. And patients in more than 3 and 4 achieve a disease response or disease control, but yet in real life, less than half of them get maintenance treatment. And that's really sad because we know that maintenance treatment overcomes the challenge of chemotherapy resistance and the fact that our patients usually progress after chemotherapy at some point. So this is something you'll be very familiar with. This was Javelin bladder, which was randomizing patients to maintenance avelumab or best supportive care alone. And they had to have had a minimum of 4 cycles of chemotherapy with either Gemcis or Gemcarbo. And this was the money slide with the extended follow-up. In fact, this has been extended again, and this is now out more to 30 months, particularly when we look at the real-world data, which I'll share with you later. And we can see that the curves separate very quickly. And so there's a 9-month improvement in overall survival. And when we look at the time of survival from the start of any treatment, so from the start of platinum-based chemotherapy, this then really starts to challenge the results of some of the other drugs that we could choose in this setting. So when we look at the efficacy data, they start to look very similar. And of course, we've been using checkpoint inhibitors for many, many years, haven't we, as a community? And so we should all be very good at managing side effects. The nice thing for my patients is that when we've looked at ongoing follow-up for more than 2 years in Javelin bladder, the safety signal remains the same. And this is also what we see in the real world data. Now, this was something that really impressed me 2 years ago. So this was something I could tell my patients the next week in clinic, that if they had already been on maintenance avelumab for a year, their chance of being on it for another year was over 90%. And their chance of being on it for another 2 years was nearly 80%. And for those patients that were already on treatment with maintenance avelumab for 2 years or more, their chance of being on it for another year and a half was 90%. And there were no new safety concerns. And interestingly, 3 in 4 patients were no more bothered at the end of 2 years of treatment than they were at the start. So the main thing that tells me is that patients' quality of life is good, they're staying on treatment, and actually that 2-week schedule that we always worry a little bit about didn't bother them at all. This is one of my favorite slides. This is looking at patients across the ages. Why would we discriminate based on age? Well, of course we shouldn't. It's about biological fitness. And we can see that actually the survival benefit is even more in the older patient. It's nearly 15 months. And certainly I treat patients in their 80s and in their 90s if they're biologically fit. It should not be a concern. What about our bigger patients? Well, in the UK, this is more of a problem. We've got fatter patients. And this is important because we know that patients with a high BMI, they can be more prone to diabetes. And this may be something that might be of concern, for example, if we're using EVP. And also, it doesn't matter whether you look at low volume or high volume disease. So these are patients with lower volume disease. You can see that you have got that survival benefit. and also in patients that, as long as they have dominant urothelial cancer, they could have other histological variants mixed in with this. And we see similar data in the real-world studies. Quality of life, well, as I've already mentioned, 3 in 4 patients reported no deterioration at 2 years. And what we can see is that quality of life is better or maintained. This twist analysis shows you in the light blue the time after progression or relapse. The purple one is time where you're well, you've no symptoms of progression and you've no toxicity. And the grey bit, time with toxicity before you progress. And what we can see is that when you look at avelumab, that there is far more people in the bit without toxicity or progressive disease. All the caveats that we have about quality of life data in studies, again, they still showed consistency of improvement in patients' quality of life and no deterioration from baseline. Now, I was very excited when Enrique Grande presented this at ESMO last year. This is a very practical academic study comparing either 3 cycles or 6 cycles of platinum-based chemotherapy before we went on to maintenance treatment. And the main endpoint of this was quality of life. And this is a really important study because we've all struggled to get patients on to their 4th cycle of treatment. And what it showed was that actually, if you were in the 3 cycle group, your quality of life was better. And actually, there is a scientific basis to this as well, because you're probably more likely to do well because you're priming, getting ready for that immune-mediated part of your treatment. So there are some criticisms originally because the number of patients that got to 6 cycles was less in the 6 cycle group, and the median number of cycles was 4.4. But that doesn't worry me, given that standard of care prior to this would have been 4 to 6 cycles of treatment. So the fact that patients' overall survival and progression-free survival was similar, but their quality of life was better, and irrespective of the type of chemotherapy they got, strengthening the data for carboplatin, then I now give all my patients 3 cycles before I switch. I'm very comfortable with doing that. And when we look at the overview now and the real world data, these are the key points I want to just mention. There are more than 7,000 patients who have had the Javelin bladder regime. They're mostly older, some of them are less fit, but the histology is very similar. But when we look at patients' overall survival, particularly in the more recent data collection sets where patients have had access to more effective second-line treatment, we can see that the median overall survival is stretching out to just under 40 months for median OS, with a median progression-free survival again out to a year. And so it's certainly no worse than Javelin bladder, and I think is actually better. And there are no new safety concerns. So this is again showing, as we've opened all these real-world studies, that we're improving bit by bit. So these are just to highlight a few of them. The Avenant study, where patients mainly got second-line treatment with EV. The EuroQ, where again you can see some of these patients went on to, after maintenance, might have gone on to EV or platinum-based chemotherapy. The Unite study from the States, the Javamax Japanese study, and then the more recent Portuguese study. And what we can see is that as we start getting more effective second-line treatment, these patients are fit to go on to second line, and we're improving their survival beyond what I ever thought possible when I started as a consultant, up to 40 months. So let's look at the other data that we have. GemCis-Nivo, I'm going to spend no time on. This was a sub-study of Checkmate 901, and we know that this really was a fairly it was positive, it was a fairly unimpressive study with a very modest overall survival benefit. And I think it's mainly down to the adjuvant component. You can see when the curves separate. So for me, this was not sufficient to change me from doing chemotherapy and then switch maintenance. But of course, we have the newer kids on the block looking at EV Pembro. And in Europe, we do still have to have the definition of platinum eligibility because that's in the licensing with the EMEA thing for EVP. So you'll be very familiar with this, patients randomized to chemotherapy or EVP. But just to remind you that 1 in 3 of those patients in the latter months of the study were allowed to receive maintenance of avelumab. That was 32% of patients. And what we've never had is the actual subgroup data for those patients. We also know that many patients in the standard of care arm did not get effective second-line treatment. They didn't get second-line EV, and it's never been fully reported. So when we look at the overall survival data, whilst this obviously is an undeniably positive study, improving the results of chemotherapy, just a few things to always think about. The chemotherapy group did better than you might expect, significantly better, where we think the median survival is 8 to 14 months, and the median one here was 15.9. So in my head, I sort of think that that group of patients that did have the maintenance avelumab probably pulled that curve up much higher, much more close to the EVP arm, but then it's dragged down by the group as a whole who did not, those 2 in 3 patients who didn't get maintenance treatment. And this is a really interesting meta-analysis looking at all of the trials we've had with checkpoint inhibitors in them. And what this showed, with all the caveats around individual patient data meta-analyses, was that actually the chemotherapy switch maintenance still did really good in comparison. So we know that EVP works quickly like chemotherapy. It's just chemotherapy given by a different mechanism as an ADC. And the median time to response is around 2 months, with an overall response rate of around 2 in 3 patients. But interestingly, progressive disease wasn't reduced that much with the combination. And their quality of life data didn't really show any real changes compared to chemotherapy. Where it is different are the side effects, and the side effects are ones that as a community we have to learn to deal with, mainly neuropathy and rash being the most common, but obviously things like hyperglycemia, which is difficult to treat. And when we look what that means in daily practice, it does mean that there are more discontinuation and interruptions and more dose reductions than we see with chemotherapy. What does that mean for our patients? Well, we honestly don't know, because we're translating the data from the previous cohorts from EV301 and from the monotherapy study. So it may or may not make a difference. And in fact, if you look at the monotherapy data that has been registered in Europe around the licensing of EV monotherapy, it would suggest that it probably does make a difference. But I wanted to spend some time on looking at the side effects with neuropathy and skin reactions, because even the grade 1 skin reactions can be problematic for patients. And remember that grade 2 peripheral neuropathy is the first time it's become symptomatic. So what this means for my patients is imagining taking out your phone now and trying to text, and imagining that you're wearing a pair of mittens. It's going to affect you every day. And this is the number of patients with residual grade 2 or more neuropathy in EV302 and 103. 50% of those had residual neuropathy. And again, residual grade 2 or more skin reactions. So this is not to be thought of lightly. And when we look at the Elevate UC study, this was nearly 8,000 patients looking at treatment-related side effects. And these are measured as events per 1,000 days. And they were obviously different depending on what you gave. So the highest rates of immune-mediated reactions and GI, renal, dermatological effects were all higher with EVP. Obviously, platinum showed higher hematological toxicity. And these were in standard patients, the ones that we might see every day with some hypertension, a bit of anemia, a bit of renal dysfunction. So when we look at these, and we don't have enough time to dig them out in detail, but what you can see that they stack up with more skin events with EVP, with more GI renal events with EVP, with cardiac events similar across all of them, and with other events more with EVP. When we look at musculoskeletal neurological events, again, you can see that EVP dominates, more hematology with carbo, as we would expect, particularly with thrombocytopenia, and then endocrine events with any of the regimes which contain checkpoint inhibitors. So we've got all these options. We know that they're effective, but how on earth do we choose the best one? Well, we proposed some criteria a couple of years ago, which stimulated a lot of debate. These were always intended to be a work in progress. They were never intended to be absolute. And what we suggested that you might want to think about patients who had a pre-existing neuropathy, significant corneal problems, poor GFRs bound down to reasons other than their cancer and obstructive neuropathy, poorly controlled diabetes, or poor performance status, which in its own right indicates a worse outcome in bladder cancer. So we did do a global survey published in The Oncologist, which showed that when we looked at these over 200 respondents, which is more than anybody ever responded to confirm the Galsky or the Gupta criteria for platinum eligibility, you can see that as a community, we were all concerned about grade 2 neuropathy, poor performance status, patients with non-urothelial dominant disease, significant eye disease, diabetes, and pre-existing skin disease or liver impairment were the ones that worried us the most. So we need to think about all of these things, the characteristics of the disease and the efficacy of treatment. And the efficacy does look very similar with all of our treatments, apart from the third option of Nebo and Gemsys, which I don't use. I don't think it's particularly effective. Access and cost, as I've said, is not just about access to the actual drug. It's about access to the clinicians that can manage the toxicity and travel costs, time off work, all of those other things. So we've looked at the survival benefits already. And also I've highlighted the fact that we're probably never likely to see that 1 in 3 patients who got chemo and then maintenance of avelumab. It would be really nice to see it. But we have also seen that if we sequence things properly and give chemotherapy, maintenance treatments, and then effective second line, we're seeing this astonishing survival that I could never have thought possible of over 40 months. So real world evidence and sequencing, what we do today will affect tomorrow, and you're going to talk about this more in a moment. But what it means is that we need to think about the best treatment choice for every person that we see, balancing the options, their individual wishes and preferences, not just looking at their cancer, but looking at the person. This is the most important person. I apologize. He is Caucasian. That's because in my peripheral clinic, the vast majority of patients that I ever see are Caucasian, and I apologize for that. But this is the most important slide I will show. He is the most, or she is the most important person, and we need to find out what his or her individual wishes and preferences are before we start offering them any treatments. And that's the true basis of shared decision making. Thank you very much.
Thank you so much, Professor Allison, for that highly insightful and comprehensive overview of evolving first-line treatment in MUC. Well, now we will move on to our next session. Maybe I request the backend team. Yes, the slides are coming up. Okay, we move on to our next session on Indian RWE. And for that, I request Dr. Sandeep Kukkar to start the session. Before that, Dr. Sandeep Kukkar is Director Medical Oncology at Park Hospital, Mohali. Sir has more than 20 years of experience in medical oncology. He has used multiple treatment regimens, including BMT, has a strong focus on personalized care and long-term patient outcomes. He has also participated into research work under the oncology department and have several publications to his name. So, Sirji, thank you very much for talking on RWE, sir. Now I hand over the session to you. Roshni, the slides are gone. Can you just...
So I'll share the slides from my end.
Okay, Sandeep, sir. Thank you.
Thank you, first of all, and ma'am, I must congratulate you. Your talk on urothelial bladder cancers was very insightful, and we have few questions from our side, and I think we'll be discussing it in the panel discussion. It was very interesting to hear how you manage the side effects. So thank you for that. And with this, I'll come on to, I think the slides are visible.
Yes, sir. Slides are visible.
Okay, just a moment. And can somebody confirm the slides are moving?
Yes, moving, sir.
Yes. So we have had a quick discussion about how the treatment has shaped up in the field of urothelial cancers particularly, and now we quickly have a look on to what we have from the Indian studies, a real world Indian study. So this is a reflection of what we have seen from the Javelin 100 trial, and we have seen that avelumab is now currently established as the standard of care. But we'll come on to what Indian settings have been. So this was basically the retrospective analysis, multi-centric retrospective analysis from 2021 to 2024, where approximately 79 patients were evaluated with a median age of approximately 62 years. Majority of them were males. The best response that was seen was approximately 20% of the patients had complete remission and approximately 50% of the patients had partial response after platinum-based chemotherapy, and they were evaluated subsequently. We will come on to the details of what the poster had to say, but some interesting findings
So KFC.
from the some interesting findings from the study were: number one, that the study was a complete reflection of what Javelin 100 had to say. Almost similar progression-free survival, in fact, better progression-free survival and a 12-month overall survival rates. Some interesting findings. Number one, it found out that the diabetics, non-diabetics are more profound to have a overall response rate, good overall response rates compared to non-diabetics. And secondly, there are some histological variations in response rates as well. If you look at the urothelial cancers with some variations versus a pure urothelial cancers, they tend to do better with the usage of avelumab maintenance therapy. So, as ma'am has already highlighted, it is one of the most common histologic bladder cancers and a 5-year survival rates of less than 5%. So this is one of the first immunotherapies anti-PD-L1 where we had nothing to offer around a decade back, and now since 2020 we have been using avelumab maintenance with a good PFS and OS, and the patients are benefiting from the evaluated drug. So the study objectives and methods were: it evaluated the real world PFS and overall survival with avelumab maintenance. It was a multi-centric, non-interventional retrospective study design where patients who had received platinum-based chemotherapy were subjected to avelumab maintenance. And what we see from the baseline characteristics, again, majority of the patients were male. The median age was approximately 62 years. There was an equal distribution of cisgem versus a carbogem regime in between the two arms. And if you look at the upper and the lower, majority of the patients had a lower urinary tract urothelial cancers. So the primary endpoint, if you look at the in terms of the response rates, so I think the majority of the patients, they had a very good overall response rate in the to the tune of approximately 74% of the patients showing a complete remission and a partial response. If you look at the disease control rate, I think majority of the patients, they responded whether they had a CR, PR or a stable disease. So approximately 90% of the patients that you can see, majority of the patients had a favorable response to therapy and very high response rates. Minimal patients showing, I think hardly 1 or 2 patients showed progression of the disease. So we'll come to the duration of exposure to avelumab as well in this the study that has been studied so far. So the best observed response was approximately 77%, and the disease control rate, as I have already highlighted, it was to the tune of approximately 98%. So if you look at the progression-free survival and the overall survival in terms of the absolute numbers, they are quite better. If you look at the Javelin 100 study, I think in Javelin 100, the median 12-month overall response rate was to the tune of approximately 75%. And here it is approximately 85%. And improvement in the similar reflection in the 12-month PFS rate was also seen if you look at the Indian real world data. So the median PFS reported was approximately a year, 13.4 months, and the median overall survival was not reached. So the Javelin 100, it is far more better than what Javelin 100 had to say. So the secondary endpoint, again, the point I was highlighting, that patients who had more than 5 months versus less than 5 months of exposure who had been treated with avelumab, very few patients had responded, but the patients who had more than 5 months of response, so it again reflects what we see in terms of immunotherapy. They kind of, those patients who tend to respond, they have a very durable and complete remission. So the maintenance avelumab offered a durable remission of the disease with continuation of avelumab in such patients. So again, this was an interesting finding, whether diabetic status and the histology. So first of all, histology, urothelial cancers with variants, I think majority of the patients had a response rate of approximately 85-86%, whereas the pure urothelial cancers, the response rates were not that high. But again, if you look at certain other characteristics, so this point was also highlighted in the Javelin 100, although it was not the pre-specified endpoint, but the exploratory analysis was done with diabetics versus non-diabetics. Again, without diabetics, it is again showing a better all and a higher overall response rates and a median progression-free survival to the tune of approximately 13.4 months versus not reached, suggesting that the absence of diabetes might correlate with a better treatment overall outcome. So the treatment summary was that avelumab maintenance offers a clinically meaningful benefit in Indian patients as correlated with the Javelin 100 data. The real world PFS and OS outcomes closely align with what Javelin 100 has to say. The key findings or the exploratory analysis showed non-diabetic patients and a high grade or variant histologies, they showed a better outcomes compared to the pure urothelial cancers. So patient and disease characteristics also significantly uh, influences the treatment outcomes, not only the selection of platinum-based chemotherapy. And the findings clearly support that avelumab maintenance is currently the standard of care as we see in the real world settings, particularly in the Indian setting. Thank you.
Thank you very much, Sandeep sir, for sharing that Indian real-world evidence on maintenance avelumab, and happy to see that the data was presented in different subgroups. So thank you very much once again. Now, with this, we move on to our central part of today's program, that is panel discussion. And to moderate the panel discussion, I'll request Dr. Vinit Talwar sir. Dr. Vinit Talwar sir is the director, Department of Medical Oncology at Rajiv Gandhi Cancer Institute. And sir has over 140 publication to his credit at various national and international journals. He is a member of various national and international societies and awarded 3 oration by different societies. He was awarded with prestigious Chikitsa Ratan Award by Delhi State. He is fellow of FRCP and FIMSA. So, Vinit sir, thank you very much for agreeing to moderate the session. And now I hand over session to you.
Thank you, Sachin, for the kind words. And let me see if I can share my slides. Just a minute, let me see.
Sure, sir.
Whilst you're doing that, I was really enjoying looking at the real world India data, because actually it fits with, wherever we see these patients. Isn't it reassuring when we actually can see that, all of the real world data, I think, supports so much what, it's not just the fit super patients that tick every trial eligibility. It's so reassuring that we can deliver those results in our own community. And it doesn't really matter wherever else in the world it's, those patients are being treated, then we're getting the same results. But then the caveat is they have to get in to see us to start off with. And that's the tragedy at the moment. I think globally we're still, we might have developed new treatments, but to those that get, more shall be given. To those that never got anything, they're still not getting anything.
Right, ma'am. The data is so reassuring.
Yeah, Sachin, can you see my slides?
Yes, sir. We can see.
They're lovely.
Now I'll put it in the PP mode. Yeah, is it okay now?
Yes, sir. It's
Right.
correct.
So before I go on, I'll just invite my panelists. Dr. Mahati is there. Is Dr. Mahati there?
Yes, sir, I'm available.
Right. Dr. Krishnanuni,
Yes, sir. Yes.
Dr. Naidu,
Yes, sir. I am.
Dr. Preeti,
Yes, sir. I'm available.
and Dr. Deepak Shukla.
Yes, sir, I'm here.
Oh, Deepak, you're there. Very nice. So we have a
Sir, we
very
also have Dr. Dharampal also with us.
okay, right. Welcome, Dr. Dharampal. So
Thank you, sir.
we have a group of medical oncologists for this panel discussion, which is nothing but a reiteration of what Professor Bertel has said till now. So as you can see in this PPT, from 1992 till 2020, there was a big hiatus. And here you could see that you had GemSys, GemCarb, triplets, or you had DDMVAC, but you couldn't go north of, say, about 14 months or 15 months. And then around 2020, you had those patients who could be given the switch maintenance with avelumab, and the survivorship went north of 29 months. And now you are spoiled for choices. You have the EV Pembro, that is EV302, and the Checkmate 901. So we'll be discussing the pros and cons of each one of them. So this has been told that you have the median overall survival of about 30 months when you include the starting of the platinum-based chemotherapy. So let me ask the panelists. Of course, Professor Bertel will be the final judge. I can ask her in between. How did you all incorporate these milestones in the clinical practice, and has it made changes in your clinical practice? So, Dr. Mahati, starting first with you.
Yes, sir, absolutely. Because once with the advent of avelumab, our first line treatment has options have changed.
You
So
can switch on the
beginning of
video if you don't mind.
yeah, sure. But I think video is a bit of a glitch, so
Oh,
I'll try.
then it's okay. Then it's okay. It's perfectly fine. There's no problem. Yeah, please continue.
So yeah, with the advent of avelumab, it has changed. So with the beginning of the treatment itself, we counsel our patients for avelumab maintenance post chemo if they have either stable or good response. So that has definitely changed our clinical practice. And with the advent of EV plus Pembro, but still, I think the most of the options we are limited because of both these regimens. If we see, they have quite a similar ineligible set of patients with poor peers and either neuropathies or age-wise. Whoever we consider as platinum ineligible, most often they do land up to be ineligible with the EV Pembro regimen also. So it all depends on the patient eligibility and fitness. If they are good, eligible, and fit, I would rather go with chemo combos followed by avelumab maintenance. That has definitely become my first line practice now.
Right. So, Dr. Krishnan, taking a cue from what Dr. Mahati said, how many patients can you actually translate into either the switch maintenance or the EV Pembro, if you talk the India-centric way?
So, I don't have
On a
first-hand
scale of
experience.
100, what would be the percentage of patients which you can embark on these two regimens?
So, from my experience, of all the patients I treated, I had given avelumab for only 3 patients, and I had not given EV pembro till now, because none of my patients are affordable for EV pembro. These avelumab, actually, those are scheme patients, so they could afford avelumab. And in that also, like if I treat some 20 patients, I think 1 or 2 will go to avelumab maintenance if there is scheme. I mean, if the financial part is not an issue. If the financial part is an issue, then it will be less than 10%.
Okay, fine. Dr. Naidu, if you talk about these regimens, now since, as Professor Bittel also said, that Gemcis Nivo doesn't come into the domain as far as the actual decision making is concerned, do you think the learning curve for any drug or any comfort, physician comfort, matters whenever you take the decision of treating these patients, or you see the protocol and you go by just by the OS, PS, or the PCR rates, or whatever you bring in your decision paradigm?
Right. So what I personally feel like, what do I do is like, one size doesn't fit everyone. Like we don't see like, okay, I don't give a blanket therapy like, okay, every patient of urinary bladder will take up for the. Instead, we'll have a proper shared decision making, looking at the patient, looking at the comorbidities, looking at the other things should be considered. And we have, when we are spoiled for these options, like we need to pick up the option which rightly fits the patient. Like most of the patients, of course, they are on avelumab maintenance out of all the people, and 2 patients are on pad cv with pembro protocol also, and one of them had severe skin reactions where later we need to stop the therapy and all. So experience, if you ask me the experience, yes, avelumab experience was good, but it doesn't make me like I'll go for avelumab for everyone. But yes, it is one of the most comfortable regimens out of the both of them. And nivolumab, yet to use. I haven't used nivo right now in urothelial carcinomas. Yet to go for it.
I'll just ask Professor Buttle. You said that you put Gemcis Nivo as a poor third. So could you just elaborate a bit on that?
I mean, the survival advantage of 2 months compared to what they have to be. They have to be cisplatin fit according to the protocol, which is the Galsky criteria, which I've never used in real life for the last zillion years because they were only ever meant to be used in the clinical trial. But yet they were adopted as being, you can't have cisplatin if your GFR is less than 60, which obviously is nonsense. I give cisplatin down to a GFR of 45. I fractionate it if it's between 45 and 50. I think it's a very modest benefit. And I think you can see when the curves separate, it's at 6 months. I think it's the adjuvant, it's the maintenance component that's actually doing anything. And why would I change from what I was already doing from 2020 with Javelin Bladder to something 3 years later that is not looking even as good, to be honest? So yeah, I'm not a big enthusiast of the sub-study 901 sub-study at all. And I think there's 0 progression-free survival. It's like 20 minutes. It's an interesting point when we look at PFS with any of these studies with checkpoint inhibitors, because I don't mind in Javelin Bladder that the main endpoint was overall survival. It was met very comfortably. What about the PFS? It's not as great. It is positive, but we're also used to treating with checkpoint inhibitors beyond radiological progression if the patient's deriving clinical benefit, because that's what we've done for years. And sometimes there's always a bit of a misinterpretation of treatment response as well. So I'm really comes with the overall survival signal. And I have to say the DISCUS study has helped me so much because there were always those patients I tried to drag to cycle 4 so I could get them onto maintenance treatment. And I always was swept along with the myth that maybe cisplatin was a bit more effective. I think we can see with Discus confirming data from other studies that actually carboplatin is a good drug, and that the only data that showed that it wasn't was the Maria DeSantis paper. That's the only one that ever raised any controversy. And certainly in my own study with POUT, we saw no difference in the adjuvant setting between GemCis and GemCarbo. So I'm very comfortable now swapping at 3 cycles. I do give EVP. I find out at the start what the patients like, what they want. And sometimes it's a really difficult decision as to what we would choose, because I do believe that chemo and switch maintenance, if you have access to effective second-line treatment, is a good strategy, because toxicity is less, and survival is as good, because we don't know what to give after EVP unless those people have got a biomarker abnormality. Unless they're suitable for erdafitinib, we don't know what to give after EVP. There's no data as to what might work. So I think we get more options and less toxicity by using sort of chemotherapy and then switch maintenance, and then using EV second line if we've got it. I have a really interesting case, a number of really interesting cases where either choice, I saw somebody last week that I've dosed with EVP rather than chemotherapy because his liver function test was dreadful. And that was because he had tumor thrombi in his portal vein. So there was nothing I could do to improve that. Anticoagulation hadn't improved things. So the only thing we could do was treat his cancer to improve that. His liver was dying, really. But yet he looked really well. He was performance status 0 with no other comorbidities. So, and gemcitabine worried me greatly with his LFTs. So we had a chat about treatment or no treatment. And in the end, I've given him EVP because I was worried about gemcitabine, not because I thought it was a more effective treatment, because I was equally worried about gemcitabine. And I've given a lot of EVP in the study. So I think I'll keep you posted, hopefully on a future webinar. We're about to have cycle 2 next week. I'm seeing him tomorrow.
Sure. You have to use your clinical discretions whenever
Absolutely.
you treat these patients. So
Patients
this
don't
was,
fit guidelines. They don't fit guidelines.
yeah, every time you can't follow guidelines. You're absolutely right. So this, you have the Javelin regimen. You can see whether you use cis-carbo or if the patient is CRPR or SD, or if the treatment interval is between 4 to 10 weeks, you can get the benefit with the switch maintenance. This, as Professor Bertel had mentioned, this is the Discuss trial in which you have 3 cycles versus 6 cycles, whether it is the quality of life indices. 3 cycles is almost similar, in fact, better than the 6 cycles. Whether it is the PFS or the OS, they are almost the same, as you can see between both the two. So the question comes, as in accordance with the Discuss study, which Professor Grande had mentioned in his study, will you start after 3 cycles or will you start after 4 to 6 cycles? Let me ask Dr. Deepak. Dr. Deepak, what would be your take, 3 or 6?
So, sir, with the availability of data from the Discuss study, we all have patients who tolerate gem carbo possibly not that well, possibly due to thrombocytopenia, low counts. With the availability of this data, we are more comfortable in switching to early avelumab maintenance. So this gives us an option for patients who are tolerating the drug. It is an option to continue till 6 cycle and then based on the response switch to avelumab. But definitely it gives us an option, particularly for those patients who are not tolerating the chemo part that well.
Right. So the next question would be to Dr. Preeti. Dr. Preeti, you have a patient who has achieved a complete response, say after 3 cycles, and you have another patient who has had only a stable disease after 3 cycles.
Yes, sir.
So does that alter your switch plan, that is from 3 cycles or 6 cycles, or uh, according to discuss, you will immediately change after 3?
Sir, so far, practically, I have been giving the chemotherapy for 4 cycles. Uh, because the initial Javelin 100 trial had suggested 4 to 6 cycles. I did have a complete response after 3 cycles for one patient. That patient was the age was also he was a little elderly person. He was having features of pancytopenia post the 3 cycles also. Hence, the response assessment scan was done at the 3 cycles itself, and we did see a very good response there. And the switch maintenance is not going to change because of the type of response which I have achieved post
No, but
chemotherapy.
definitely,
Still,
if you have a complete response at 3
yes,
and you switch versus you just have a stable disease at 3 and you switch, the responses are slightly different. Although, you're right that both of the situations, the patient would be responding. So would
yes,
you
sir.
go the
Both
discuss way, or would you or would you use your clinical discretion in this situation?
if the patient has got a complete response and the patient has not has not tolerated the chemo well at 3 cycles, and if the patient has had a complete response, then yes, definitely I would prefer to go ahead with a maintenance therapy at that point also, because that would be much more safer and a viable option for that patient. So it will be an individualized treatment practice, patient to patient basis.
Yeah, fine. Dr. Dharampal, what are your thoughts on this? You have a patient at 3 cycles, complete response. Would you like to give 3 more cycles and the patient gets the toxicity of these drugs, knowing very well that
Sir,
if the patient is having CR only on chemotherapy, majority of the patients come back after some time, despite having a CR. So will you stop at 3 and you switch, or you continue till 4 or probably 6?
sir, as of now, definitely that we have an evidence that we can shift to maintenance after 3 cycle without more toxicity of. So based on this data, we can stop after 3 cycle in the patients who have not tolerating well, where we have concern of cytopenia, where we have elderly frail patients, kind of cisplatin ineligible patient. But as of now, in our clinical practice, we are still practicing 6 cycles, sir. We are going on maintenance after 6 cycle, but definitely now we have evidence that we can switch after 3 cycle. In subgroup of patient, at least where we need to stop chemotherapy early.
So I think Professor Bottle will have the last word. 3 cycles, can we switch over now since we have the discussed data, or we
Yeah.
still, have to manipulate?
I changed the week after. So I was sitting at ESMO when Enrique gave his presentation. And my initial thought was I was a bit surprised that people in the cisplatin arm didn't get all 6 cycles, because that's tended not to be my experience. And initially I thought, the median number of cycles in the intention to treat 6-cycle arm was only 4.4. But then actually I argued with myself and said, well, they'd have been getting between 4 to 6 anyway in real life, because that was the Javelin bladder protocol. So it doesn't matter that the median number was 4.4, because that's what I'd have been giving them, between 4 to 6. So 3 is better quality of life. It's the same in terms of the impact on the cancer from a survival viewpoint. Why wouldn't I change? So I changed the following week, actually.
So I think with the given data now, there is some clarity that after 3 you can change over and you can switch. Also, if you see this the age factor is a big problem in patients of urothelial carcinomas. So irrespective of the age, whether it is 60, 70 or 80, you still have good overall survival in these patient subgroup. And like the Checkmate study, you have a good response in the lymph node only disease, where Checkmate had the best response in patients who had lymph node only disease vis-a-vis the other sites. So the question again, this I'll pose to Dr. Mahati. Elderly patients, multiple comorbidities, multiple challenges requiring individualized treatment. Do you follow a uniform approach, or do you sway away from the standard lines of treatment?
No, so as I already said, it's especially for our Indian setting, it's all about patient age and tolerability. That is the first thing that comes to our mind because, as Professor Ellison has already mentioned, it's not what the guidelines say. It is how well we appropriate the guidelines to the patient as such. So yeah, I would be individualizing the therapy to the patients depending on their tolerability and comorbidities, definitely.
Fine. Dr. Krishnan, patient with low tumor burden, do you opt for aggressive upfront treatment, or rather you go blunderbuss, or do you plan to go in a sedate way and then reserve treatment options for later lines? So,
So like those patients with I will be starting with chemotherapy like Gemcarbo. I will be starting. Then if the patients are going up for a good response, then I will offer them with maintenance, switch maintenance, because these these urothelial carcinoma patients, advanced disease, and mostly elderly patients. So we are not sure whether we will be later, whether the patient will be fit for a later line. These aggressive treatments at a later line. So I will try to give the maximum treatment upfront itself.
So I think that is the logical way to go about, give the best first, because as all of us know, when we embark on the second line treatment, most of the patients, they slough out, and you have only a small percentage of patients who are actually fit for the second line of treatment. Dr. Naidu, do you consider diabetes as an important parameter to plan your treatment? Now, I am referring to the switch versus the EV Pembro, where you have hypoglycemia as a very important side effect, as Professor Bertel had mentioned. So, with that in mind, would you, think one over the other, or it is not that important in decision making per se? Is Dr. Naidu there? Or probably Dr. Deepak, you can take this.
Yes, sir. Diabetes definitely. Again, we should take into care whether it is a poorly controlled diabetes or it is a well-controlled diabetes with existing end organ dysfunction in terms of residual peripheral neuropathy. We know that possibly beyond grade 2, we do not have an option of giving EV Pembro, as EV's main side effect is peripheral neuropathy, and it is an exclusion criteria. So definitely comorbidities and diabetes definitely are taken into consideration in the treatment planning. But again, how well controlled and the associated end organ dysfunction associated with it is equally important.
Again, I would refer to Professor Bertel. Madam, Monday
I think
morning, how would you go about a patient who's a bad diabetic, who has brittle diabetes? Would you choose one over the other?
I wouldn't give them EVP. I mean, I was part of that survey. I was the co-author on the paper for the oncologist, which again, that survey around, do we need eligibility criteria for EVP? And the answer was yes, because we've got eligibility criteria for pretty much most drugs. And the survey was completed by over 200 oncologists from most territories across the world. So again, that's more than putting together the Galsky and the GUPTA criteria. And most people felt that, particularly for people who'd never used EVP, you need to have a framework around it. Diabetes worries me greatly because the hypoglycemia you get with EV is not sensitive to insulin. So once they've got it, it's really hard to reverse it. And we know that you can say, well, and Tom frequently says, well, get them seen by, get their diabetic control improved, if their HbA1c comes back high, get them to the diabetologist. This is bladder cancer. We have not got time to wait for several weeks while we optimize somebody's diabetic control just so that they can get onto a particular schedule of treatment that may or may not be better for them for survival. I personally don't think it necessarily is. So my patient last week, who I was really worried about giving gemcitabine to, so I gave him EVP on a reduced dose of EB. His HbA1c came back as high. He was already diabetic. He was on metformin. So I increased his metformin from 3 to 4 tablets. And then he promptly got diarrhea, which I was then not certain whether it was going to be immune mediated or not. So it was very tricky. And I think, poorly controlled diabetes, we don't want to be giving them EVP unless you want to wait another 6 weeks, which I don't think we've got time to do in this disease, particularly with high burden disease. And low burden can become high burden very quickly in urothelial cancer. So no, I definitely wouldn't. And the problem in my population is we've got large numbers of people who are overweight, whose HbA1c is at the upper limits of normal already. These people have often got some hypertension. Then you've got a bit of hypertensive or diabetic nephropathy as well. So you're starting to stack up things which in isolation might not worry you, but once they've got them, and if they've got a pre-existing neuropathy, because as I said, grade 1 is asymptomatic, grade 2 is going to affect you, picking up your pen, sending a text. So I think we have to be really careful with people with pre-existing problems such as diabetes.
Yeah, you're right, because I had one patient on EV who had a very good response, but he said, what good it is to me if I can't tie my buttons. He had about grade 2 peripheral neuropathy. So that is a practical problem. And here, as you can see, which you've also shown, that treatment-related adverse events leading to discontinuation is about 1/3. Interruption is about 2/3. And dose reductions are about 40.7%. And this is something which is very, very distressing, that even after the completion of treatment, about 40% have residual skin reactions, which can be mighty irritating, and 50% have residual grade 2 neuropathy. So this was the global survey, which was done in patients with EVPEM and grade 2 sensory neuropathy, ECOG status of more than 3, and more than 50% non-urothelial complications were the ones which were distressing. So, Dr. Preeti, how important is the adverse event profile for selection of therapies in palliative settings? This is just, your thoughts. Is Dr. Preeti there? Or Dr. Dharampal, adverse event profiles for selection of therapies?
Hello, am I
Yeah,
audible?
you're on.
Definitely, sir. Just
Some
Dr. Preeti is also there. I guess she was locked out in between.
right.
Dr. Preeti?
Dr. Preeti, can you answer this question? Importance of A profile for selection.
hi, sir. Can I audible now? So sorry, there
You're on.
was some interruption in the.
Yeah. Please go on.
As you ask a question regarding the toxicity profile in the palliative setting. So, hello.
Yeah, you're audible. Please continue.
Sir, in metastatic CA urinary bladder, we generally see patients are in elderly, frail patient. Patients are cisplatin ineligible. They have some another comorbidity like a cardiac issue. So, and we know that with the use of the all of the agent survival is, if we talk about the maximum PFS, which have EV plus pembrolizumab. So definitely toxicity profile is important. We choose the drug which can improve the quality of life with minimum side effect.
Yeah, so you would be
No.
inclined to think on those lines. I agree with you.
Yes,
So
sir.
going to the real world evidence, first we see the avelumab. You find that the median PFS is almost mirroring the registration trial, and so is the OS in most of the trials which have been carried out across the world. And the number of patients are also quite significant. It's about more than 5,000 patients. And if you look at the EV Pembro trials, it's around 900,000 patients in 3 centers. And there you find that the ORR rates and the disease control rates and also the OS and PFS are slightly different from what it was seen in the registration trial. And all of us know that the robustness of any trial is much there when the real world evidence mirrors the registration trial results. So with that in mind, uh, Dr. Mahanti, how important is the real world effectiveness and the safety of first line regimens in advanced UC?
Yes, sir. Coming to that, I would rather be very excited to look at real world data and much more excited to look at the real world data from our Indian setting. Because practically for me, if I look at my center, nearly around 35 to 40% of patients who come to my center with advanced UC are ineligible for cisplatin. And roughly around 50% may be ineligible for any sort of platinum therapy. So, real world data will give us an insight on how these therapies are going to work in such a setting.
Right. Taking a cue from what Dr. Mahanti has said, Dr. Krishnan, do you make any manipulations in cisplatin depending upon the GFR? Say, if it is borderline 35-40, do you split it or do you straight away go for carboplatin or any other manipulations?
I don't split it. I straight away go for carboplatin. So that's the way I treat. I don't split cisplatin like Madam has already told.
I see. Dr. Naidu, what is your experience? Say a patient has GFR 40% or 45, 40 ml per minute or 45 ml. Would you switch over to carbo or would you give cis, say, day 1, day 8 with gem? Dr. Naidu is not there. Dr. Deepak, what is your take?
Yeah, so sir, possibly in these patients, we must rule out any reversible cause. So any obstructive uropathy, which could be reverted by use of PCNL or DGN stenting. So by doing these procedures, we can make some of the patients who are initially at present cisplatin ineligible to being eligible. And some of our patient, as you mentioned, I do split dosing. So I'm very comfortable with splitting the dose.
Yeah, sometimes we tend to split the dose whenever we find that you can use your clinical discretion. The comorbidities are not that much. Professor Bertel, you also mentioned about dose splitting in certain patients. Uh, how comfortable are you in this situation?
I'm very comfortable, and in fact, there have been a number of studies over the years, involving so the cytosine study with adding nintedanib neoadjuvantly, you were allowed to use split dose cisplatin in the neoadjuvant setting. You just had to stipulate beforehand, and I've always used split dose cisplatin for patients who've got a GFR of between sort of 45 and 50, over 50. Most of the time, I give them standard, day 1 cisplatin rather than splitting it. And then below 45 down to 30, I give carboplatin. I'm very comfortable. I also treat testis cancer. So I think when we think about the issues of toxicity, I'm curing most of my patients with testis cancer, but I feel dreadful when they come to clinic with peripheral neuropathy. I've got one patient who's in a wheelchair because I've been treating patients for a long time. And obviously the trade-off there is, you know, their cancer was going to kill them, but they have got a long life. Now, you could say with a palliative treatment, if you've got an effective palliative treatment, and some people obviously argue are very much in favor of EVP. Some people, like myself, think that actually if we, you know, chemo switch maintenance is still a very good option, and then second line treatment. But I wouldn't necessarily want, you know, to give that patient for the rest of their life toxicity that they're going to remember every day in a palliative setting. And even if you are helping them to live longer, that therapeutic index of benefit to toxicity sort of becomes even more important, I think, because I want somebody to have good quality life. If I'm making them live longer, I still want that life to be as good as possible. I don't want them spending all of the time in hospital with complications of my treatment, because then I feel guilty about it. So if they're going to live X months longer because of my treatment, they don't want to be spending 4 months of that time in hospital or with extra visits to healthcare providers because of that, and with all the costs that might incur to them, not just, you know, around the financial costs, but time when they could be doing other things that they would enjoy.
You're absolutely right. Dr. Preeti, taking an offshoot from what Professor Bertel has said, do you observe similar outcomes when you see these patients in your clinical practice, EV-PEM versus the switch maintenance? What are your thoughts on that?
Yes, sir. Sir, I have not used CV plus pembrolizumab in my practice so far. So, but yeah, the safety of the first line regimen, definitely the further the quality of life post chemotherapy for a patient in a palliative setting is very important, because despite having a good response, the patients they are not able to live peacefully with the n amount of side effects which might occur during therapy as well. So that is definitely not the way they would want to have a survival, even if the disease has come down. So definitely choosing a regimen which would be suitable for the patient, and tailor the treatment according to the patient also is very important. And especially in the palliative care setting, where the quality of life and plays a big quality of life plays a major role while treating patients as well.
Fine. So this was the post-hoc analysis of EV101 and 301, where you find that if you make a dose alteration, that adversely affects the outcomes, the overall response rates. So let me ask this to Dr. Dharampal. Dr. Dharampal, have you observed low-dose EV-related impact on efficacy? Keeping in mind that about 40 to 45% of patients had a reduction in dose when EV-PEM was given.
Sir, definitely, this EV is not a good drug in terms of side effect. There is a lot of side effect with most of the time. I have not used in so much patient, but most of the time this drug need dose reduction and dose modification. So because of the side effect and reduced dose, the effect on the efficacy, I think we generally go up to 75% dose or 70% dose. I think that is okay for efficacy.
But that would affect the outcome as per these studies 101 and 301. And these are the proportion of treatments across the therapy lines, and attrition rates have improved in the recent years. Professor Bertel, have you seen this in your actual clinical practice, that you've been able to get more patients on board, whether it is second line or third line, or there's not been much change?
I think because we're seeing patients on maintenance, more regularly. And that 2-weekly schedule, you know, when I first started, I was a bit worried that it might affect patients' quality of life. But the fact that they're still turning up for it, and actually the only time they start asking about it is when they're on that, you know, I've got 2 people who are on their year 4 at the moment. And of course, they may be cured. So there's that conversation around, do they want to still carry on with treatment or not? But I think because they're seen so regularly with the scheduling, you pick things up probably earlier and you have a lower threshold for scanning if you're worried about somebody. So I think that's actually one of the beauties of having a regime that means that people come regularly, because they're seen often, you know, they'll be seen often by the same healthcare professional, the same chemotherapy nurses, and they can pick up subtle changes. So I think we're able to get more people onto second line treatments because we're seeing them that regularly. And it's, you know, once they're on second line treatment, they don't, you know, the incidence of immune mediated side effects is low because we've been using checkpoint inhibitors for years in other cancers. So we're pretty good at picking up side effects very quickly. And so I think more people are well enough because we've not missed the boat for them starting second line treatment because we're seeing them.
Talking of the morbidity, talking of the morbidity, please.
Yeah, I think with Pembro, the thing is, if they've had to stop EV and they're just continuing on Pembro, and most people end up stopping the EV and just continuing on the Pembro bit. The issue with that is that, you know, you can use a 6-weekly subcut version of Pembro. And you're not seeing patients as often. And if they've been established on it for a while, you know, they're sort of in and out. So I actually think in some ways it's an advantage of the scheduling with maintenance of avelumab that we're able to pick these patients up. I think more people go on to second line treatment. My second line patients after EVP, I don't know what to give them. I haven't a clue. I give them chemotherapy. To be honest, so far I'm deeply unimpressed with giving it a second line treatment. And the number of people that have got a positive biomarker for erdafitinib is tiny, really tiny.
And there are some papers in which for EVPEM you're using nectin as a biomarker. What are your thoughts on that? Is it a good biomarker or?
So 2 schools of thought. The EV302 team led by Tom, who say it doesn't matter, it's overexpressed, it's not predictive of response. Then there's the fact that they've never published the data of their assay, so nobody's been able to reproduce that. Then you've got the data from Markus Epstein and Nick Klumper that says something very different, where it says that expression differs between the primary and the metastasis. It says that it also differs between cytoplasmic and membrane bound, that it is closely tied to efficacy of treatment. So I think it's a really important biomarker for treatment response. I think we should be doing it. I think it should be funded. I think we should have one consistent assay if we're going to do it. And I think with the development of new ADCs, particularly those that are targeting things like HER2, then if you were looking at giving patients an ADC, if that was your treatment strategy, and you've got somebody who's Nectin-4 low, you're not going to be giving them enfortumab. You're going to be looking, if they're HER2 high, you're going to be looking at them giving a HER2 targeted treatment. So I think it's really important. And I think the fact that we've never seen the paper yet, there are 2 papers we've not seen from 302. The group that had maintenance of avelumab, their subgroup analysis, and the details of the assay used for the Nectin-4. Those are the 2 things. They published pretty much everything else, but not those 2.
Yeah. So, Dr. Deepak, Professor Bertel has already answered the first question. What are the usual treatment sequencing therapies used in clinical practice? Say, suppose you've given EVPEM prior. Is there any role of a second immunotherapy drug after that? I give you two situations. One is that the patient has progressed, say, in a short period of time, and the other one has been taking pembrolizumab for more than 1 year. Will you use a IO? Yes or no? And then the other thing is, apart from this, what would you give in the second line?
So, sir, possibly IO re-challenge, I'll say no. The first situation, I have a patient who progressed quite early after avelumab maintenance, but he then received docetaxel and he responded for, let's say, around 2 years. Then I have to stop it because there was no progression. And he continued on observation alone for around 8 to 9 months, and he's doing pretty much okay. So possibly one of the reasons could be pseudo progression due to IO, which I have stopped early. So in this situation, I can consider re-challenging because it has been some time since I gave it initially. And patient who is progressing already on Pembro, I don't think even if he is progressing, let's say after a year, doing something, adding chemo and then continuing with Pembro, I think we do not have data for that.
So there are some phase 2 studies which say that IO after IO does not make much of a sense. Dr. Preeti, first line platinum based followed by switch, patient progresses. What would be your choice in second line? Do you look for biomarkers like FGFR, HER, or something else, or would you put the patient on EV or chemo? What are your thoughts on that? Is Dr. Preeti there or Dr. Dharampal? Dr. Dharampal or Dr. Mahanti?
Yes, regarding
Yeah.
this particular setting, yeah, I would be definitely
So you
looking
have
for
given the patient switch. After that, would you go for chemo? Would you check for FGFR? Would you check for HER? How would you, you know, uh, guide your treatment across?
So post switch therapy, there is I right now have one patient on avelumab maintenance who progressed after just 6 months on avelumab. I would definitely be looking for biomarkers, but meanwhile, if the patient is if it's available, then I would be starting him on EV.
You'll start on EV. Uh, any other, say, suppose the patient is FGFR positive, he has FGFR alterations, would you not give a FGFR
I
than EV, or
Availability is a problem in our setting.
suppose
I
availability is not a
have
problem? Or okay, let us see HER 3 plus by IHC. What would you do? Would you still give EV or would you give a ADC or whatever?
I would rather give EV and then go for HER3 in the third line.
Okay, you'll give HER in third line. So third umpire, Professor Buttle, patient has HER IHC 3 plus. Would you go for a EV in second line or would you give a HER block?
So I sort of think there's no point doing a test if we're not going to act on the results. What would worry me is if the patient becomes unfit subsequently to have their biomarker directed therapy, we've missed the opportunity. So we've wasted doing a test, which they may or may not have had to pay for. So I think if they have a biomarker positive, and I feel like there's in prostate cancer as well, I think if you've done the test, why would you not act on it? So I would probably in this situation give it, if they were FGFR positive, I'm going to give them erdafitinib, and I'm going to reserve chemotherapy for once they progress on erdafitinib. But I admit that we have little in the way of sequencing in that line, and that's mainly because of we need to put huge data sets together. You could argue it either way, but if I've got a drug that's biomarker selected, that's reimbursed, and I did the test to show that it was going to be positive in the first place, then I'm going to give it.
Yeah, that would seem more reasonable. But as you rightly said, you can argue it both the ways. Now, since we are short of time, I think this would be the last question. Dr. Deepak, what are your thoughts on the histological subtypes and the impact, given the view that the switch maintenance works good on most of the subtypes?
Yes, sir. Definitely, histological type should be kept into considerations when we are planning treatment. So, avelumab data is particularly good for all the subtypes, while particularly for the rare subtypes, the EV pemro data is thinner. So, once these rare subtypes are there, in those setting, I think avelumab maintenance should be preferred.
Right. And these are the graphs where you can see the median overall survivals in the different trials. And you find that there's not much difference when you give first line switch and then you put the patient on second line EV versus giving EV first and then you are lost, you are midway how to go about in these patients and also the side effects which are there with EV. Although having said that, you can, this is food for thought, this chart here, we can go either ways. And of course, we need predictive biomarkers whenever we individualize the treatment. And as Professor Bertel has rightly said, if you have tested for a marker and that marker is positive, one should employ it, quickly into the treatment paradigm, where it would be, more precision guided treatment than just hunting in the dark. So one size does not fit all. And I think I'll stop here. I thank my esteemed panelists and Professor Bertel for engaging in such a good panel discussion. So over to you, Dr. Sachin.
Thank you so much, Vinit Talwar, sir. That was wonderful panel discussion. And as always, you threw some questions which really made our panelists to think and answer it. So thank you very much. You did it as always. With this, we have come to the end of today's this interesting session on urothelial cancer. For final thoughts, I request Dr. Meenu Walia, ma'am, to share the final thoughts.
I must thank all my colleagues, Dr. Allison, especially Dr. Vineet Talwar, and all other colleagues for a wonderful discussion on this difficult to treat and an aggressive malignancy. And probably, I think that is one thing is very clear today that for especially for urothelial advanced aggressive cancers, now we have many options. We have chemotherapy, we have immunotherapy, we have ADCs. But what is the problem today is not which option, rather than which drug to come and when to come. It is the right sequence that will decide the fate in majority of the patients. And today we learned from our colleagues the real world evidence, whatever is present, and probably how to use the drug in the right sequence, and also the personalized patient problem. We know that every patient is unique, and then we need to monitor for the side effects also. And let this be an enriching experience, and let's put this into a practice, and then share and encourage such meetings to share such experiences further also. With that, I say thank you to all.
Thank you very much, ma'am. And on behalf of Merck Oncology, we thank everybody for starting from Dr. Meenu Walia, ma'am, Professor Alison Bertel, Sandeep Skoker sir, Dr. Vineet Talwar sir, and our esteemed panelists, who made the panel discussion really, really interesting with their real experiences. And we hope that this discussion is insightful and relevant for your clinical practice. And we look forward to see you in our future meetings. With this, we conclude today's session. Good night, everybody.
Thank you very much and Happy New Year.
Thank you so much,
Thanks.
Professor.
Thank you.